Welcome, Rad-Onc residents, to this high-yield explainer. Today we're cutting straight to the chase. We're going to distill those pivotal trials, the must-know mnemonics, and the critical astro guidelines that you absolutely need at your fingertips, whether you're rounding on the clinic floor or gearing up for your board exams. Think of this as breaking down that massive, sometimes overwhelming landscape of breast cancer radiotherapy into the most actionable, evidence-based insights. Let's get right into it.
Here's our roadmap for today. We're covering 1. Systemic therapy and chemoprevention, 2. Omitting radiotherapy in early stage, 3. Whole breast hypofractionation standards, 4. The tumor bed boost, and finally, 5. Accelerated partial breast irradiation. We've purposely structured this to mirror the exact clinical decision tree you face every single day.
All right, starting off with Section 1, Systemic Therapy and Chemoprevention. Before we even think about drawing our radiation fields, we've got to establish the systemic coverage, right? So, to help you instantly recall the mechanisms of action for these common endocrine therapies when you're being pimped on rounds, let's break down some mnemonics. For tamoxifen, think TAM, tissue-acting modulator. It selectively blocks estrogen in the breast, but acts as an agonist in the bone. For exemestane, remember X, as in extinguish forever. It's an irreversible, suicidal aromatase inhibitor. Then we have anastrozole. The A stands for always reversible. It sits on aromatase for a bit, then leaves. And finally, letrozole. L means let's go. It's another temporary reversible aromatase blocker. Keep these memory hooks handy. They'll totally save you when you're put on the spot.
Moving right along to Section 2, Omitting radiotherapy in early stage.
So now that we've got the systemic side locked down, we face our first major Rad-Onc decision. Exactly who can safely omit radiation entirely after breast-conserving surgery? We have literally decades of data trying to answer this exact question. And the goalposts? Well, they've been steadily shifting.
Let's trace how those shifting age cutoffs actually played out across the landmark omission trials. It's like watching a timeline evolve. We started with CALGB 9343, which required patients to be 70 or older with negative margins. Then Prime 2 came along and lowered that threshold to 65, as long as they had at least 1 millimeter margins. Fast forward a bit, and the Lumina trial safely brought the age all the way down to 55 for low-risk luminal A patients. And finally, the IDEA trial really pushed the envelope down to age 50. How? By introducing genomic selection. They specifically required an Oncotype DX score of 18 or less, alongside 2 millimeter margins.
The actual clinical trade-off we're making here is fascinating. When comparing the data on local control, omitting radiotherapy clearly leads to a drop compared to patients who receive it. That's just a fact. But, and this is the absolutely crucial part, when evaluating overall survival in these highly specific older cohorts from CALGB 9343 and Prime 2, omitting radiation does not negatively impact overall survival. Not at all. It's a calculated risk weighing local recurrence against the overall treatment burden for that specific patient.
Okay, Section 3, Whole breast hypofractionation standards.
Look, while moderate hypofractionation is absolutely the standard of care now, you must know when not to use it. You've got to lean heavily into this mnemonic for the Whelan trial exclusion criteria. Just remember, big, bad breast. Big stands for a tumor size greater than 5 centimeters. Bad reminds you of bad surgery, meaning positive margins. And breast refers to the patient's actual geometry, specifically a breast separation greater than 25 centimeters. Lock this into your brain. It's a lifesaver for clinical rotations.
We use hypofractionation because the data just powerfully supports it. Evaluating the outcomes across the START and Whelan trials, it's crystal clear that moderate hypofractionation is absolutely not more toxic than standard fractionation. In fact, and this is a real game changer, the START-B trial, which compared 50 Gray and 25 fractions to 40 Gray and 15 fractions, showed that the 40 Gray regimen actually results in lower late normal tissue effects. We're talking less breast shrinkage and fewer telangiectasias. It's a win-win.
Moving on to Section 4, the tumor bed boost and balancing those clinical risks.
The classic EORTC breast boost trial gives us the exact hard numbers we need when we sit down to counsel our patients. The main takeaway here is the trade-off. Adding a 16 Gray boost significantly drops local recurrence from 10.2% down to 6.2%. That's great, but it comes at a very real cost. Consider the fibrosis rates. Severe fibrosis jumps from 1.6% up to 4.4%, and moderate fibrosis literally more than doubles, going from 13.2% to 28.1%. And, the kicker, there is zero overall survival benefit. Both arms sat exactly at 82% at 10 years. You always have to weigh that recurrence drop against the cosmetic reality.
And finally, Section 5, accelerated partial breast irradiation.
So, if we can treat the whole breast faster, it begs the question, can we safely treat a smaller volume of the breast altogether? To safely practice APBI off trial, we rely heavily on the ASTRO guidelines. You really need to delineate the two extremes here to build a pragmatic mental framework. On one hand, the suitable patient is generally age 50 or older with clean margins of at least 2 millimeters. On the exact opposite end, the unsuitable patient is someone under 40 years old or anyone with positive margins. Basically, if your patient falls into that unsuitable bucket, partial breast irradiation is completely off the table outside of a clinical trial.
Now, evaluating the varying local recurrence rates across the major PBI trials, like NSAP B39, RAPID, Florence, and UK Import Low. What you really need to keep in mind here is that these trials used vastly different techniques. We're talking everything from twice-daily external beam to once-daily regimens to intraoperative approaches. Overall, the local control is generally very good, but the specific technique being used is what drives the subtle differences in recurrence rates we're seeing.
The breakdown of cosmesis and toxicity brilliantly illustrates the nuance of the data we just talked about. Notice the massive spike in moderate to severe adverse cosmesis. We're talking approaching 30% long-term in the rapid external beam trial. Why? Because it used 38.5 gray and 10 twice-daily fractions. Now compare that to the Florence trial's phenomenal cosmesis using a once-daily 30 gray and 5 fraction regimen. It essentially proves that in partial breast irradiation, your dose and fractionation schedule profoundly impact the patient's cosmetic outcome.
To wrap up this explainer, I want to leave you with a really powerful golden rule straight from the EBC-TCG meta-analysis. Have you ever wondered why we obsess so much over tiny margin measurements, boost doses, and exact fractionation? Well, here's the so what. For every 4 local recurrences we prevent by year 10, we prevent 1 breast cancer death by year 15. That right there is exactly why this high-yield evidence matters so much for our patients. So the question to ask yourself next time you're contouring is, are you maximizing that local control for year 10? Keep that in mind as you head back onto the clinic floor. Thanks for joining me, keep learning, and we'll catch you next time.